queria convidar, então, o Alfredo Palacios, do IEX da Argentina, para apresentar sua fala sobre da custo-efetividade ao acesso sustentável, uma abordagem unificada, né? From Cost Effectiveness Analysis to Affordability, a Unified Approach. Alfredo, por favor. Obrigado.
Right. Well, good morning, everyone. My name is Alfredo Palacios. I'm a researcher at the Center for Health Economics at the University of York. And today I'm going to help me with the presentation. Okay. I'm going to talk about how we can think about cost effectiveness analysis and affordability in a more unified way. And also I would like to say thank you for the invitation. And of course, Paul and I are really happy about being here with all of you. You know, I'm originally from Argentina, so I'm very happy to be in South America. So let's start. And I would like to, okay, something is happening with the presentation. Okay, let's see. Okay, right. Thank you so much. So I would like to start my presentation with a really important, but at the same time challenging question, that is, how can a treatment, we can think in a healthcare intervention, a drug, could be cost effective and at the same time unaffordable. I mean, this could look like a very unusual situation, but in general it's quite common. You can think in a situation in which, for instance, an HTA agency could say, okay, we evaluate this particular drug. This drug seems to present a good value for money. This is cost effective. But when the drug arrives to the healthcare system, the responsibles of the budget say, okay, it's okay that it's cost effective, but we are not able to afford or to pay for this particular technology, and that is a very quite common situation. I can imagine that most of you are very familiar with cost effectiveness analysis, with budget impact analysis, but for those who are not very familiar with these approaches or tools that we have in HTA or HTA and decision making, I'm going to say that in general, cost effectiveness analysis focus on try to determine if something is or a technology is a good value for money. It's a question about efficiency of the use of the healthcare resources. And budget impact threshold budget impact analysis is a bit different. The question is, can we afford the bill for this particular treatment or this particular drug? And of course, I'm going to try to combine these two question in a framework. So these are not like a theoretical question. These are like a very specific cases in reality. And for that, I would like to talk just a bit about this particular example, that is the hepatitis C dilemma in the UK. In 2015, I think, some new drugs for hepatitis C were considered like a very valuable in terms of the clinical benefit. That were a proper cure for this disease. In the UK, the HTA agency that is NICE conducted an evaluation, a cost effectiveness analysis about these technologies, and they say, okay, this drug are cost effective, so the healthcare system should cover this drug for hepatitis C. But there was a massive problem, and it was that the responsibles of the budget, that is, the NHS in England, say that we cannot afford this. This represents a massive budget impact that is in this figure is really, really close to 800 million of pounds. That is a massive amount of money in the UK. And as you can see, represent a figure that is close to 1% of the total NHS budget. So it's a massive amount of money. So the problem was, okay, we have this technology that is very valuable, present a clinical benefit for the patients. It's a good value for money, but we can't afford it, So I mean, and of course, this was related to some characteristics of this treatment for hepatitis C. For instance, very high prices in terms of acquisition cost, but also the cost per patient. As I showed you before, a massive budget impact for the healthcare system. And in addition to that, a massive upfront budget shock, in terms of that these drugs needed to be paid just in the first year, causing a massive shock in the budget. And also because of the calculation of the eligible population, that there were some uncertainty there. Of course, we were having some uncertainty in the potential implication in the budget. So all of this set of characteristics was creating this kind of challenge, of this paradox in which we have cost-effective drugs, but at the same time unaffordable. And as many of you can realize, these characteristics are not just for drugs for hepatitis C. These characteristics are also present for, drugs for rare and ultra-rare diseases. So I hope that the rest of my presentation could be useful in order to inform not only the debates about affordability and budget impact, but also for decision-making related to drugs for rare and ultra-rare diseases. So I would like to talk just a bit about the conventional approach to cost-effectiveness analysis. I'm trying of not using any mathematical formula here, which is very challenging for me, But in general, I mean, the basic process in an HT agency that is trying to conduct a cost-effectiveness analysis is to say, okay, we should calculate the cost associated with these new technologies and old technology or a standard of care. We should calculate also, the health benefit associated with each of these technologies in terms of quality that represent a year gained in perfect health. So we are considering years and also the quality of those years. And after that, we should compare the ICER, or the incremental cost effectiveness ratio, considering the cost and also the gains, with something that we call a cost effectiveness threshold, that we call it K. I'm going to discuss with more detail about this cost effectiveness threshold, but at the moment, let me say that this is like the conventional approach. And if the ICER is lower than this threshold K, we will say, okay, this is a good value for money, and the opposite if the ICER is higher than this cost effectiveness threshold. But something that is important to reflect here is that, in general, this cost effectiveness threshold that I will show you soon, that represent the health opportunity cost of the system, is that in general, this approach works very well for some small scale decisions, in terms that they are not having a massive impact on the budget of the decision makers. But if we try to evaluate healthcare technologies with very important budget impact, this conventional approach alone probably is going to lead to suboptimal decision making. So we would like to try to go more in detail about this approach and some potential improvements here. So something that I would like to make very, very clear is that when we face this paradox, I mean, in terms that we have a healthcare technology that represents a good value for money, I mean, it's cost effective, but at the same time, it's not affordable. This means that we are having an issue because our cost effectiveness threshold is not reflecting properly the opportunity cost. So again, if we see this paradox in which a drug is cost effective but not affordable, is because we are having an issue in the threshold in terms that is not reflected the opportunity cost. And as you can imagine, the opportunity cost for us is very important, and it was something that we were mentioning just from the first presentation of this morning. So I'm going to go with some detail about the opportunity cost. As I said before, the question about affordability is a question about the opportunity cost. And it's very important to have in mind that the true cost of any new technology or healthcare intervention or drug is not merely the price tag of that technology, it's the opportunity cost. And this cost try to represent all the healthcare, the health benefit that are foregone from other services, such as, I don't know, cancer screening, mental health services, cardiovascular programs, etc., that should be displaced or defounded because we would like to, to pay for the new technology. And that is the concept of this cost, the opportunity cost. Try to represent all the health that we are going to forgone because we want to, to provide funds for or pay the new technology. So based on this, and of course, from my point of view, the key question in this issue is not, can we afford this drug or if we cannot afford this drug? Instead of that is, which health services are we willing to sacrifice? And of course, if that sacrifice represents a worthwhile decision or a worthwhile trade. And it's really important to mention here that it doesn't matter the budget of if we can create a new budget for some specific diseases, or even if we can increase the budget for the healthcare system, we will need always to make a sacrifice in order to pay for a new technology. So the decision is, okay, so the question is, which is that sacrifice we can measure and we can value that sacrifice, and also if this represents a good exchange between our available services and the new drug. I mean, we cannot avoid these decisions because even, of course, it will be really good that, the politicians say, okay, we are going to increase the budget for the healthcare system, and that will be really, really good. But even though those new resources could be allocated to, other type of technology, for instance, cancer treatment, cancer screening, vaccines, etc. So even if we have an increase in the healthcare, so okay, there are a lot of empirical evidence that suggests that the threshold for the healthcare system in the UK is something around this figure. Of course, there are many updates in this study, but in general, the result is quite consistent. That is around this value of £12,000 per quality adjusted life year. This is a very, very important study conducted by Carl Claxton from the University of York. And there are so many improvements in this type of empirical analysis, and the result is always the same. Even when we have more data, more details, better methods, etc., it's very clear that the threshold should be that value that represents the opportunity cost. So, but here we're talking about affordability and budget impact. So a quite relevant question for us is how the budget impact or the budget pressure impact on the opportunity cost. Because at the moment, we were talking about just one threshold that used to work very well with with not very big budget impact. So which is the case if we are facing massive constraints, and what is going to happen with that opportunity cost? Well, the good thing is that there is more evidence, some studies conducted in the UK that are trying to reply to that question. I mean, how the budget impact or these new pressures impact on the opportunity cost, and therefore impact on the cost effectiveness threshold. And you know, in the UK, we have these local health authorities that we call primary care trust, or PCT, that are responsible for managing the local budget and try to, you know, to provide care to the population based on, of course, some healthcare needs, and they have like some target that they need to accomplish. I mean, they receive some budget, and they should, you know, present some accountability about the results that they are getting with that budget. And of course, there are some PCTs that could be considered that are under the target, and I mean, these are the PCTs that are receiving less funding that their proper needs, and therefore they are more financially constrained. And there are some PCTs that are over the target, so they're receiving more funding than their needs, and therefore they are having less financial pressure. So we have two types of units with different budgets, and of course they are going to have different health outcomes, and we would like to see how efficient they are in order to create health based on the budget that they have. So some results about this, as you can see in this table, is again in the first row we have like a general estimation of the cost or opportunity cost threshold in the first row, considering all the PCTs, and in the last row you can see which is the opportunity cost threshold for the PCTs that are more financially constrained. And as you can see, they are more, I mean, they are more efficient creating health in comparison with the over target PCT, because they are facing more constraint. So they have to make smarter decisions about how to allocate that budget to the different healthcare technologies. And in general, they try to prioritize the technology that are creating more value in terms of health. So as you can see, they are having a lower opportunity cost threshold than the over target PCTs, and of course that the average of the PCTs. And this is, even when this is a local study conducted in the UK, is presenting like some very informative lessons, because this is exactly that I said before. But the most important lesson about this study and this kind of experiment trying to identify the efficiency of the under threshold, under target PCT and over target PCT is that when we have in a healthcare system and we receive or we estimate a massive budget impact, that is like the system is acting in a more constrained situation, and of course that is going to have an implication on the cost effectiveness threshold, and of course in the opportunity on the opportunity cost. I'm going to present this in more detail, but again the intuition I think is a bit straightforward, you know, in the way that we are going to face a high budget impact. Our system is going to be more constrained, so we need to be more efficient in order, you know, to represent which is the real opportunity cost for those resources in this constrained situation. But of course, at the moment, we were talking about just one particular threshold, considering, all the PCTs, and of course, the conventional cost effectiveness analysis is having some limitation when we consider this situation in which we have a massive budget impact, and that is related that in general the conventional cost effectiveness analysis is invariant to the scale of budget impact. I mean, we can have an incremental cost effectiveness ratio that will be exactly the same if we have a budget impact of around 1 million versus 1 billion of pounds. So the conventional cost effectiveness analysis is not representing the scale of the budget impact, and that is a limitation in order to inform decision making. At the same time, as something that we were discussing before, is that the conventional cost effectiveness analysis neglect the budget impact timing. I mean, in the specific case of the drugs for hepatitis C, the cost effectiveness analysis will present exactly the same result. Doesn't matter if we need to pay now immediately this 800 million pounds versus if we can get some kind of agreement in terms of payment, such as having some small installment across time. And conventional cost effectiveness analysis is not able to represent the timing of the budget impact. And something quite similar is happening with the uncertainty that we can expect in the budget impact. If we are not able to identify properly the target population, of course we are going to observe some heterogeneity and some uncertainty in the budget impact, and of course that is going to affect the opportunity cost. And conventional cost effectiveness analysis is not able to reflect these characteristics that are quite common in high impact budget impact drugs. So something that we would like to present here as a valid alternative to the incremental cost effectiveness ratio is something that we call the net health benefit. The net health benefit is exactly the same or the same component as the incremental cost effectiveness ratio. The intuition is that the net health benefit of a technology represents the health that we gain in the patient population, providing coverage to this new technology, excluding the health opportunity cost of this investment. Here I present, sorry for this, I'm able to see some faces of concern about the formula there for the net health benefit, but just let me tell you that this will be the only mathematical formula I'm going to introduce in this presentation. I swear for the most important thing that Argentinian people have, that is Lionel Messi. So I'm going. This will be my only mathematical formula, I swear. As you can see, in the right hand of this equation, we have a measure of the incremental benefit associated with the new technology, that is the incremental QALYs, but also we should consider here, the health opportunity cost that is represented by incremental C. That is a measure of the budget impact, and the parameter K represent the cost effectiveness threshold. This is something very, very common and standard. I didn't introduce any significant change here in this equation, and this equation is exactly the same as the ICER, but expressed in a different way. And the main idea here is that if this net health benefit is higher than zero, okay, we can consider that this new healthcare technology provide more benefits than harm to the healthcare system. So this is exactly the same formula, so no worries about that. I didn't lie. In order to incorporate the budget impact within the cost effectiveness threshold, we are going to replace the simple threshold K with a function that will be K depending on the budget impact of the technology. So it's not a very massive change is just instead of having a fixed threshold, we have a function, and the meaning of this is that the cost effectiveness threshold will change depending on the size of the budget impact. If we have a really small marginal budget impact, the net health benefit formula will be exactly the same as we saw in the previous slide. But if we observe a very important budget impact, okay, the threshold is going to change in order to reflect this. And which is the implication? Believe me in this, if we have a higher incremental C, I mean a higher budget impact, we are going to expect to see a lower threshold and value K, and this is going to suggest a higher health opportunity cost. And that makes absolutely sense because, as I said before, when we have a massive budget impact threshold, our healthcare system will be more constrained. So we need to have a lower cost effectiveness threshold in order, to reflect the proper opportunity cost of providing coverage to this technology. So the opportunity cost will change, So let me check something. Okay, this is okay. The slides are not moving. I don't know if someone can click probably in the presentation. Okay, great. So there are so many technical details that I don't want to provide because it's not the main point about this presentation, but I will be very happy discussing about all of this after the presentation, the Q&A session, or later today or tomorrow. But something that is really important for us in terms of decision making is, to try to reply this question and using this framework that I think is quite useful in order to try to reply this question is, of course, if we observe that we have a technology that is creating, a proper value, in terms of clinical benefit, but also in efficiency represented by cost effectiveness analysis, and of course, we would like to cover this technology. The question is, okay, how can we minimize or try to reduce the budget impact in order to, to not create some collateral damage in terms of that we need probably to sacrifice plenty of available and very valuable resources such as cancer screening or different programs for cardiovascular condition, etc. So this is again exactly the same formula. So Messi is okay for the next World Cup. So here in this framework, you can see again I highlighted with yellow color the budget impact in our net health benefit formula. So if we would like to incorporate valuable technologies with clinical value, we need, to reduce or try to reduce the budget impact. And the good thing is that we have three ways or three complementary ways in doing this. The first one is negotiate prices with manufacturers. I mean, I'm talking about try to, get discount, rebate, in few words, try to reduce a lower acquisition cost. If we would like to reduce the health opportunity cost of our decision, we need to get lower acquisition costs, and we can do that through negotiation with pharmaceutical companies. Second, we can try to, to spread the payments. In general, these high cost or high price technologies in general require to, to do a massive upfront payment, such as the case of hepatitis C drugs. But if we are able to, to reduce, or try to smooth the payments across the time, we will be able to reduce the budget impact in the first period and also in the subsequent period. So this is an important point for try to empower value-based payment models with manufacturers. And the final point is related to uncertainty. As we said before, we can expect massive uncertainty in this type of, in the budget impact for these particular technologies. So a way to reduce that uncertainty and therefore try to reduce the health opportunity cost is to try to, to enable and empower value-based risk sharing agreement with manufacturers. And of course, we can try to do all of the three things in order to reduce the budget impact and therefore to try to have a better profile of net health benefit for a technology that possibly provides clinical benefits. So I think that I'm on time. So muito obrigado.
Thank you very much, Alfredo, for your explanations. And to clarify for us, what does it really matter? That it's the opportunity cost, and how does it implies in the efficiency of the system. And I think it was very interesting, your mathematical demonstration and your innovative approach in how to connect the cost effectiveness analysis with the budget impact. I was very interested in your approach. Thank you very much. So with the matter of time, we will connect your presentations with the poll presentation. And then after poll presentation, we're going to open to the questions to Alfredo and also for Paul. So we're going to open a round of questions after Paul presentation for both the presenters. Thank you very much.